room today for a very important subject. We have an expert with us on chart documentation today. The title may be documentation, but the significance of it is much different, because when we document well, it improves our personal physician profile with our insurance providers. It improves overall reimbursement for the hospital system in which you work in. If the hospital is better reimbursed, they provide you more technology to work with that makes your job better and more fun and improves the outcomes of your patients. So this is much deeper in subject content than just documentation. So we appreciate your coming. We appreciate Dr. Jon Arnott here today. He's from Ohio. He's affiliated with the training institution in Northeast Ohio Medical Center, and he's the clerkship director for the Department of Medicine there, among other things. I'll let him further introduce himself, but Jon, thank you for being with us, and just finish in 10 minutes and we'll be fine.
Okay.
No.
Thank you. So I'm Jon Arnott. I am a general internist. I'm a hospitalist. The last time I saw a patient was Friday. Okay. I get home Friday. You can guess. The next time I see a patient will be Saturday. So, while I'm talking about a subject that doesn't sound like, it's going to benefit me scientifically or whatever, it absolutely will. Okay. And normally I don't wear a suit and tie. I wear scrubs, and so I do feel a bit overdressed, but you'll have to put up with me. Why did I even get into documentation? Well, the first thing is I made the cardinal mistake as a young attending. I went to a committee. Then I raised my hand and I had an opinion. And that insightful opinion then got me to become a chairman of a committee. And you can see how everything goes from there. So, in my hospital, we had a problem with mortality. And the Ohio Department of Health came and visited us and said, you guys are killing way too many patients. If you don't fix this, we're going to fix it for you. Now, at that point, we decided they're not nice people. They don't seem like they have our best interests. We should probably get on top of this. What we saw was we had a lot of patients where the obvious end was near, but our documentation was scant. And what we documented was documented in a way that the coder was not allowed to use that documentation. The documentation didn't speak to the severity of illness of the patient. Because of that, for that period of time, we had a very, very low, profile. People's opinion of our hospital through publicly reported data would have been absolutely, terrible. So we fixed it. We worked hard on it. We were finally, given an award by U.S. News and World Report. We were listed as one of the 100 least deadliest hospitals in the United States. The problem is, it's not a good billboard. Less deadly. Come here. Bring grandma here. We're less deadly. It didn't work. That wasn't good. So we enjoyed the gravitas of that, but we couldn't market it. I've been tasked with talking to 3 groups in specific to your own, departments. It's going to be a bit hard for me, and I'm going to have to really get through a lot of stuff with you guys. I just want you to understand, normally I do a much broader lecture. We're going to talk about specifics for all departments, but I want you to understand, whatever you're admitting and taking care of, it's the other stuff going on with the patient that the hospitalist is taking care of that you need documented to help you out. And likewise, the hospitalist that has a patient that goes to surgery that had some big stuff going on, we need your expert documentation. It all works together. We're a team. As much as we're not a team when it comes to who's going to take that admission in the ER, we're a team as a group in the building overall. And on my service with my residents, they're always going, well, why are we taking this one? And I go, because somebody's going to be the doctor today. Let's take the patient. No big deal. I don't care. To me, it's just I'll see as many patients as I have to see. That's what happens when you're in practice. Here are my objectives, my disclosures. No off-label, that's easy. And I have no financial disclosures. I don't own any pharma stock or anything else. All I have is a bunch of abysmal mutual funds, so I don't have any great financial things to declare. This is a great case. And anybody want to just take a quick shot at interpreting this CAT scan? Just don't speak up all at once for me. Okay, so the radiologist correctly identified this about 98% of the time. Okay, adenocarcinoma, they were successful at declaring that was a neoplasm. Here's the problem: about 86% of the time in what was called the angry gorilla study, the radiologist missed the superimposed angry gorilla. And I know the lighting's a little bit bright, but if we take it down just a little, you'd be able to see this here. So the angry gorilla showed that the radiologists were so good at doing what they always did clinically that they just moved on. As a group, as physicians, we're good at doing what we do clinically, but we tend to just move on when we're documenting. We don't get everything down correctly. We're missing some angry gorillas that predict mortality. Documentation has a lot of uses, okay? A lot of uses. And so when we talk about it, it's important to understand it's to support the decision to admit a patient or continued stay, or actually help get your patient from the hospital onto an acute rehab or subacute rehab. If we don't have the right documentation to support that, we can't qualify our patient. Our patients paid for their medical insurance through their lifetime. If they need to get to a long-term acute care, if they need to get to an acute rehab, they deserve to have that ability. So our appropriate documentation aids in their continued stay elsewhere, their recovery. Obviously, there's some other reasons for it. And finally, it justifies physician billing. And that's important as we go forward, because you'll see in a couple slides why I say that. I just want you to talk about documentation accuracy. I don't want to be out here saying improvement, improvement, improvement. There are people that talk about it that way. I want you to understand, if you're evaluating it, managing it, and treating it, you deserve to get the full credit of the work you're doing by having it appropriately written. Our coders have to speak a dialect to the federal government. They're not allowed to deviate from that. We speak our physician dialect. We write it in abbreviated forms, and every one of us understands what's being written, but coders are stuck. They literally have to use what is written appropriately. If it's not written appropriately, you did a ton of work, you're not getting credit for it. And the coder can't submit that. So that patient's severity of illness is understated. A couple years ago, CMS had changed the rules. Those rules had some profound effects on us. It took about 6,000 things that they felt were ubiquitous. Since everybody had them, nobody gets credit for those for severity of illness. Then they said, well, we'll add a couple extra words to them so they count, okay? The problem is, you don't know about them, okay? So we got to fix that, and that's what we're going to do today. We all know we're being profiled, okay? Whether it's Health Grades or any other organization, they use data. Health Grades, do you think Health Grades is going out and checking data, or are they buying their data? They buy it, and the data they buy is called MedPAR. And MedPAR data is owned by CMS. So whenever a physician bills for hospital services or a physician bills for outpatient services, all that information is going into CMS. All the hospital information is CMS. Anything is going into CMS. The MedPAR data bank is the largest patient data bank in the United States. and I would say one of the largest in the world. But it's only made up of traditional Medicare lives, okay? Not commercial, just traditional Medicare. That's your sickest patients. So if you're understating your severity of illness for your sickest patients, imagine the problem, because the other patients, the least sick, sometimes the ones that are easier to take care of, they're looking at our profiles, okay? So we want to take care of our profile. It's also important to understand that just like the RAC audit, there's the Zone Program Integrity Contractors. Now the RAC audit looks at hospital submissions and says, well, you didn't have the right documentation to support this. So over this 2-year period, over this amount of cases, about 40% of them fell out. They calculate a penalty and they say, okay, it's about $2 million. You can pay us $2 million in fine, or you got 30 days to defend this. And whatever you defend it down to after we've gone through it, that's what you owe us. Well, the ZPIC audit is for physician billing, okay? And so physician billing and DME and physical therapy, the problem with that, when they look at this, is when we don't have that extra $100,000 in our wallets to pay CMS on the penalty, how do they fix it? Oh, well, you're going to work it off, okay? Obviously, you're going to work it off with some interest, so it's a lot of extra work. You don't want to get into a ZPIC audit, okay? So if it's physician billing, it's based upon whatever you've documented in your office and in the hospital, and that's why this is important. Medicare Severity Diagnostic Related Group is the inpatient way that Medicare evaluates the care we give and figures out how to reimburse the hospital for expenses. If the patient was considered a low complexity MSD or G, that's because there was no documented complicating feature or comorbidity. Okay? You could have treated it all along, but it wasn't documented in the King's English, so to speak. If there's moderate complexity, then we've had a complication or comorbidity documented in a usable fashion. And then if it's high complexity, it's because we had a major complication or comorbidity. Every one of our diagnoses that we have has a value. UTI, low complexity, 0.78 relative weight. The higher the number, the sicker the patient. Okay? You can look here. Now, heart failure is at 1.51. Here's appendectomy. So you can come in the middle of the night, do an appendectomy, no complication comorbidity, it's at 0.94. Now, a lot of appendectomies don't have a complication or comorbidity. Maybe they didn't have any hypovolemic shock. Maybe they did, okay? But here's the other kicker. CMS also gave something called CPD, okay? Complicated principal diagnosis for appendectomy. So I had to go meet with our coders and go through what's called the coding clinics. I wanted to know what were the diagnoses that qualified for the CPD that obviously took appendectomy from 9 to 3 if there's a major complication. And so we went through it. Here's the only diagnosis they gave. Peritonitis. I mean, anything like virtue of an acute abdomen, peritoneal signs, inflammation, peritonitis, even seen in your pathology report. Kind of odd, but that's one of the things that they have. But this is the thing that gets me mad the most about this. Somebody comes in with cystitis, they're not even septic, okay? 0.78 severity of illness. A guy comes in, uncomplicated myocardial infarction, dies, 0.76 in severity of illness. Cystitis, sicker than a dead myocardial infarction. There's no complication. Acute myocardial infarction, expired, uncomplicated. Now, I think you're laughing, but it's reality, you know? And as a guy with a couple heart attacks, stents, and an open heart, you know, I'm really offended that they would do that to some of my friends that didn't make it. Okay, so we have some real heavy lifting that we have to do. We have to see what are the things we have to fix. If you took every case you had taken care of, took all those relative weights, totaled them up, and then divided by the number of cases, you'd get a number called the case mix index. Okay, that's your credit score with the federal government. Okay, that case mix index should match up with things like actual and expected mortality, or average length of stay, or average direct costs, or discharge to nursing home, or discharge to home health care. That should start to match up. It should tell a story. It's a credit score. The higher the number, the sicker the patient. The lower the number, the less sick the patient. As a general surgeon, I should be offended that an internist is going to have a higher score than me because I didn't have any words on that appendectomy, okay? And I like to say that a lot. When I was in Arizona, a couple guys that I used to practice with just up the street from me were out there. So right that day I was saying, Raul, how do you like it that you had to get up and take care of my appendectomy while I slept, and you're not even ranking with my COPD patients? So, you know, that's one of those things. We want to get the right information. We write checks out of Uncle Sam's checkbook. We're creating a carbon footprint of data, so to speak. We're creating our tracks of our reputation. It's important we get credit for what we do. We're missing a slide. There it is, out of order somehow. Okay, so here's a case in 2006, right out of my hospital, right when the rule changed. The family medicine resident wrote a very nice looking H&P. The assessment section is right here. And so it's an elderly female admitted for unsteady gait, watery diarrhea, vomiting, chills, leukocytosis. Okay? White counts 30,000, 94% polys, low hemoglobin, low MCV, low albumin, pulse ox is 81, BP is 83 over 52. The chest x-ray magically had an acute vertebral compression fracture. Okay? How they could tell that, I don't know, but they did. That's what they interpreted. And a right basilar infiltrate. Anybody got a diagnosis? Anything? Aspiration pneumonia, maybe? Hypoxemic respiratory failure? Severe protein energy malnutrition? Septic shock, right? We go with that. And there's probably something really nasty going on in the belly, okay? Came from a nursing home. This probably caused all those things, okay? The problem was we only have one real diagnosis in their documentation, acute vertebral compression fracture. So this case came out as medical back pain. That's what the coder was forced to use. The patient died within 6 hours. I failed to mention, she's 95. There's no code for 95, okay? You could be 50 or 95. It doesn't matter. It's what you write, okay? So, you know, here we have a death with medical back pain. Back sprain, back pain shouldn't happen. The chart had symptom excess disorder. Lots of symptoms, no diagnoses. This destroys profiles. It destroys hospital profiles, physician profiles. Your profile, wherever you go, is still going with you. You're carrying that around with you. So, vertebral compression fracture would come out to 0.87 in relative weight today, expected length of stay of 3 days, $4,500 of direct costs. That's what we would spend as physicians to take care of the patient. You know, not the muffins, the coffee, the auditorium, the brilliant speaker that you have in front of you. None of that cost is in indirect costs, okay? I expected maybe a laugh out of that or something. So, you know, then there's pneumonia. That would come out at 0.7. Or urosepsis. Today, urosepsis means cystitis. October, it doesn't mean cystitis. It's never meant sepsis, okay? But we say that. I know what you mean. You know what you mean. CMS doesn't. That doesn't work with them. So had we written aspiration pneumonia and septic shock, or aspiration pneumonia and severe protein energy malnutrition, we would have gotten full credit for aspiration pneumonia with a major complication comorbidity. So you get the idea. There's not a lot of extra writing you have to do or typing. It's just getting the right phrases in front of the things you're treating. You're treating them anyways. Okay, so it's an acute exacerbation of COPD or severe protein energy malnutrition or coma. You know, how many times do we write coma? Yet, do we not have patients on Presidex or fentanyl and propofol or other schemes to keep them stable while they're ventilated? Right? We even induce that coma, but we don't take credit for that severity of illness. Where do we document? It has to be in the treated part of the chart. So we all document in these areas, starting in the ED, your H&P, your notes, your consults, your OR and procedure notes, discharge and expiration summaries. It has to be timely. If your discharge summary is a month late or your operative notes a month late, I'm going to guarantee you, coders, they got about a 4-day window where they're supposed to get this stuff out. Okay, because what do we know in hospitals? We got to keep the lights on. We can't hold up stuff waiting for that last amount of information. Missing information sets us up for a lower physician profile. It sort of takes us and puts us in a box. We took care of a very hard case, but we didn't get the credit for it. So we want to be on time. The primary diagnosis, the primary DRG, it could be heart failure, COPD, a delivery, it could be some kind of surgery, it doesn't matter. The primary diagnosis doesn't change. What changes it is all of the secondary issues, okay? So here we have a AAA. AAA, very simple, we look at it. If we diagnosed renal insufficiency, heart failure 10 years ago, you were good. Okay, now today, no credit for any of these, okay? Even though this patient might be the same as this patient and this patient. So, the difference between CKD5 and end-stage renal disease by GFR, does anybody know? Trick question, there is no difference, it's the same GFR, okay? Why is one end-stage and one CKD5? Duration of the disorder. If you're doing 1 through 89 days, you're still in CKD. If you improve, you're going down the ladder in CKD. But if you don't improve, you're end-stage renal disease. If you're a cloner, cut and paste past medical history, or cut and paste previous diagnosis problem list information, you've probably taken CKD5 that's really ESRD. You're cheating yourself, okay? You don't want to clone, okay? You don't want to look at something and repetitively do your dictation. You want to be able to get the right information there. So heart failure, malnutrition, this gets you to a moderate level of severity of illness. Qualifying the severity made a difference for severe protein energy malnutrition or acute systolic heart failure. And think about this. They're compensated, they come in, we give them lots of fluids to get them through the surgery, do whatever. There's some SIRS going on. All of a sudden, we're giving them some Lasix. Now it's acute on chronic heart failure, okay? So we want to capture that. In the ER, you should be looking for things such as SIRS, sepsis, hypovolemic shock, acute hypoxemic respiratory failure or hypercapnic respiratory failure. You want to think about acute lactic acidemia. You've measured acid in the blood, okay? It's not acidosis once you've measured it, okay? If you've gotten it measured, it's acidemia. You get credit for acidemia. Your patient's not sick when it's acidosis. The system doesn't give you credit for stuff like that. If it's happening acutely, you should call it acute. Whatever it is, it should be called acute. There are some really oddball things that go from not sick to severely sick with the word acute. Here's an example. Acute epiglottitis. Honestly? Really? Had to write acute for that? Yeah, but we do, okay? Acute delirium. You know, an extra 4 days, a bunch of family conferences, right? And if you're on night float, it's a disaster with your delirium patient. But they're not really delirious until it's acute delirium. And if the LV-EDP goes up to 22 and greater, acute systolic heart failure. So in the cabbage population, you could be looking at that. Let's talk about shock. How often have you written shock this year on a chart? Anybody raise your hand if you've done it? Okay. You know, maybe I need to have you guys just do the wave so get you energized and get you to get your hands up for something there, you know. But so shock's a serious medical condition, profound widespread reduction, effective tissue perfusion. You know, it's got cell dysfunction and organ failure. And so when you look at those organ dysfunctions, you know, encephalopathy, you know, it said confusion in Cecil's, but I took the liberty of putting the right word there for you. We're all pretty good with tachycardia, but bradycardia we kind of miss. And, you know, we're good with some of this stuff, like myocardial ischemia, which we'd call a type 2 myocardial infarction, by the way. Ileus. So in general surgery population, ileus is a manifestation of hypovolemic shock or hemorrhagic shock, and even a calculus cholecystitis. DIC, thrombocytopenia. Thrombocytopenia, we don't give it enough credit for severity of illness. Acute kidney injury or pre-renal azotemia, but really it's acute kidney injury and then acute renal failure with tubular necrosis. Anytime we treat shock, we should give it a first name, whether it's hypovolemic, cardiogenic, extracardiac, septic shock. We want to put that first name on it. And we don't want to call cardiogenic shock when the balloon pump's on. We want to capture it a little bit earlier than that. But I'm more amazed when I come into units in my hospital and that, we'll see people on balloon pumps. 50% of the time, nobody's written cardiogenic shock. We're treating it. They're sicker than anybody else we're treating at that moment. We need to write it down. Any big intervention that you do that you don't normally do needs a diagnosis, an appropriate diagnosis. Anything done on your behalf by anesthesia needs a diagnosis, okay? So when anesthesia is giving a fluid bolus, we want them to get either oliguria, hypovolemic shock. When we treat arrhythmias, we need the arrhythmia to go along with that intervention. And if it takes a long time because after anesthesia, they're just not perking up and they keep staying hypoxic, like my mother-in-law did a month ago, never had, you know, anesthesia before. So she had post-operative pulmonary insufficiency, okay? And we document that and then explains the prolonged period, why she didn't get to the floor so easily. This is by far the most annoying thing that happens in documentation. You get asked, are you treating acute blood loss anemia? So, you know, first, it's not in my Cecil's or Harrison's. It's not in my MKSAP. I don't think it's mentioned on the app site. Am I right or wrong? Do they have questions on acute blood loss anemia? No, of course not. It's a coding phenomenon. But it's part of their dialect, okay? So, you know, if you're treating hemorrhagic shock, we'd want you to write, you know, hemorrhagic shock, or acute gastrointestinal bleeding, tell me the site. That'd work just fine. But, you know, if they query you and they say, you gave a couple units of blood, were you treating acute blood loss anemia? You know, if that's the case, you want to go with that, document it, just like that. We get in trouble when we get too explanatory. We say, well, it's expected. Not really. Not every GI bleed gets blood, okay? Not every hip fracture gets blood. It's a select group of patients. It's the sicker group of patients. And then if we get too explanatory and we say, well, it's due to surgery, what that means in the coding world is we perforated, we lacerated, we caused an unexpected loss of blood. A complication, not one that helps us, but one that is a complication code that says the institution created a complication. So this is the type of stuff that we have to understand. Social history. Now, I practice in Youngstown, Ohio. We got good social history, okay? We got our amount of our homelessness and that. We party, okay? I mean, I admit 70-year-olds for stroke and heart attack because they were doing cocaine, crack, okay? You know, they like to do heroin. I got 85-year-olds that are still on methadone. I called the clinic. I said, how much does he take? 80 milligrams twice a day. I said, what? You know, we get down, we party. We don't have casinos to take our time away. You know, we have to work it. I know you don't have those problems, okay? But we want to document alcohol abuse or opioid abuse or sedative abuse. We want to get those things down. On top of it, we want to talk about dependence with those items, okay? Were they physiologically dependent upon it? Was it acute use or chronic use? Heart failure. This is important from a standpoint here. We want to know, is it acute, chronic, or acute on chronic? It's one of the three. It's not unspecified, okay? It can't be anything but these three. And then the mechanism, systolic or diastolic. You know, pulmonary hypertension, not recognized. It wasn't there in the medical descriptions when ICD-9 was written. ICD-9 was written when the Brady Bunch was in its first run, okay? So pulmonary hypertension, not there. Sometimes you have to use old terms like acute cor pulmonale. Respiratory failure. Now, I grew up in the blood gas days, okay? So I look at gases a lot, and my residents will say, but the SATs are good. And I get the gases, and they go, oh, yeah, not good, okay? So we have our typical respiratory failure criteria. If we do, we want to say whether it's hypoxemic or hypercapnic. But here's the problem. We got a lot of people with respiratory failure. We're treating, we don't even know we're doing it. BiPAP. If you're using BiPAP, they either have chronic respiratory failure or acute respiratory or acute on chronic. My dad would come in for COPD. He was always with an acid or pH of 724, okay? He was always profoundly low. He was in respiratory failure. Finally, I said to my one friend, the pulmonologist, I said, hey, when is he going to be acute on chronic respiratory failure with an acute exacerbation of COPD? He goes, oh, today. I didn't know it made a difference. And if you're using high flow 6 liters of oxygen per chest criteria, that's hypoxemic respiratory failure. Let's talk about sepsis quickly. New criteria 2013. They're saying, you know, documented suspected infection plus one of the criteria. Not 2 SIRS criteria, but 1. And it's expanded criteria. So you have your typical SIRS, but you also have encephalopathy. You also have plasma C-reactive protein elevation. Okay, so you get a lot of bone, tissue, areas that are infected. That measurement, consistent with sepsis. Okay, let's look at the organ dysfunction and tissue perfusion variables. And just for sepsis, a lactic acid per New England Journal of Medicine, 1 millimole or higher is sepsis criteria, even though 1 millimole is still within the normal value at my institution. But their point is most people aren't even that high normally. So if they're cruising up to 1 and above, they got sepsis probably if there's an infection. Okay, so here's the organ dysfunction, tissue perfusion variables. If you have organ dysfunction, which also goes along with our shock talk, you have severe sepsis, a 36% inpatient mortality. When we call it severe sepsis, we're locking down on somebody being sicker than the septic person. So, you know, hypoxemia, oliguria, bumping creatinine, coagulation defects, paralytic ileus, thrombocytopenia, 100,000 and less, and hyperbilirubinemia. Okay, so you have sepsis criteria, severe sepsis criteria, and over here, obviously the old one, hypotension refractory to fluids, now hyperlactinemia of 4. septic shock, okay? So we have a lot of abilities to make these diagnoses. In pneumonia, don't call it HCAP, okay? HCAP, it's garbage. It doesn't go anywhere in coding. So if you're hanging vanc, call it out as MRSA pneumonia. Call it out by the bug you think you're treating, okay? That's acceptable. You're allowed to do that. Let's skip confusion and call it encephalopathy. My mnemonic of very poor mist, vital, psych, metabolic, infection, structure, toxin, and you can blow through with a bunch of things that can cause it, all the way bradycardia or hypoxemia, acute delirium, encephalopathy, but you get my idea. Get yourself in the habit of calling it encephalopathy. My son, he was middle school, and I had that slide up, and he goes, oh, Hidden Mickey. But it's just a reminder for me to remind you that laboratory, radiology, echoes, pathology reports don't count. They only count if you take those clinical entities and put it in your chart. And stage 4 cancer doesn't count, but if you say lung cancer with brain mets, now that counts. So you have to tell me the site of metastasis so it has relevance. Malnutrition, 55% are undernourished of our elderly, 85% institutionalized. We can go by these physical exam elements, or we could go biochemically. If they come in with the albumin here, you have severe protein energy malnutrition, 56% increased mortality. The problem is they usually come in a little bit above that, but there's enough surgical literature that an albumin of 3 in the SICU for a surgical patient, 50-50 mortality rate. I like prealbumin. It has a 2-day half-life, so if they're MPO post-op, I can get over to my severe protein energy malnutrition. And I can use that measure as I replete to see if I'm effectively helping the patient. It's important that we diagnose BMI, have the BMI and morbid obesity, BMI 50, super morbid obesity, but it's also important here, BMI of 19 goes along with cachexia, marasmus, goes along with severe malnutrition, immunocompetent patients, or patients with advanced cancer. So we want the BMI and the cause, important for us to do. Obvious pressure ulcer there, but there's a deep tissue injury subtly right there. That deep tissue injury is going to open up. Don't call that a pressure ulcer when it's a deep tissue injury. So look at some wound care stuff to get the idea how that works. Surgical specific stuff, and I'm going to have to really speed up because I got to get through all the disciplines here. You kind of really want to use these words a lot. The HPO, hemorrhage, perforation, obstruction. Anytime you see something with hemorrhage, all of a sudden all these things became worse, okay? When you see something that's not quite, the H word there, hematemesis, or hemorrhage of the GI tract, or hemorrhage of the rectum and anus. And I say that is because these ones don't carry the same major complication as the first slide. They're still important, they're complications, okay? But just understand how that works. Perforation, wherever it's perforated, use the P word, okay? Liver and spleen, you can get an idea, and you have the handout, so I'll let you refer to those. Anatomic specificity within your GI malignancies, important that we do it this way. As ICD-10 comes in, this will become more and more important. If you learn this, you're going to be ready for ICD-10. CMS showed there's about a 95% correlation between CDI and ICD-10. More anatomic specificities. For gallstones, is it acute, chronic? Was there cholecystitis? And was there obstruction or not? That's what you need to diagnose, okay? Same thing, and then over to traumatic injuries. I'll let you review that. Let's talk debridement. When we do debridement, okay, we need a very good note describing what we did. Was it excisional or blunt debridement? When we did the debridement, what did we use? Was it a scalpel, scissors, other sharp object? Was it an aquajet, a blunt object? And then specify down to the level of tissue, skin, subcu, fat, fascia, muscle, bone. You know, where did we get to? Okay, we want to know that because that's very important for the coders to be able to take care of what you've done. Avoid calling it a non-healing ulcer or just soft tissue, okay? Every time we do that, we're sort of taking away everything. I debrided soft tissue in a non-healing ulcer. Well, yes, you did, but in coders' dialect, they need to hear this. ENT, you know, it's acute is important for you, obstruction is important for you. Then talking about whether it's an open wound, and then whatever complication would go with that, hypoxemia, etc. Other ones for ENT specifically, we got some abscess, the cellulitis, and with cellulitis, remember we can also look for sepsis, so look at that sepsis criteria, particularly like C-reactive protein, and some other complications for ENT. This is important, okay? In the past, in ICD-9, you could say tobacco use disorder, and it meant your patient was a smoker, okay? Going forward in ICD-10, tobacco use disorder is going to say, yeah, they smoke. Like a cigar on the golf course 3 times a year, okay? Not a smoker. They don't have dependence. They don't have any lung disease or hypertension or vascular disease, okay? That's not who we take care of usually. So the nicotine dependence code, that's the area you're going to have to go look at in ICD-9 or 10 to find what you want. So if they're going outside to smoke with the gown on and an IV pole, they have dependence. If you put a patch on them, they have dependence. So they have dependence and then tell us what they did. Cigarettes, and you just find the appropriate code. There's a website that I use. It's very easy. It's the only thing I do to learn ICD-10. ICD-10data.com. It's free, it's searchable, it's so logically available, very easy for you guys to go forward with. OB, we got to have APD, so antepartum, postpartum, and with delivery. Whether it's eclampsia, antepartum, postpartum, or with delivery, you can see every one of those is mentioned in that way. We want to talk about preeclampsia and whether there's pre-existing hypertension or not, and whether it was antepartum, postpartum, with delivery. So you can see how that works. It continues over here, but now there's a severity issue. You can do severe preeclampsia, or you have mild, but if you want to put the severity down. If it's severe, you definitely want that on your chart. That's the sickest patient you're treating. Hypertensive codes for OB. Documenting abortion. First, was it legal, illegal, or spontaneous? Okay. After that, you want to document, was it complete or incomplete? And then, if there is a complication, either embolism, renal failure, or shock. Okay. Those are the things you want to document. I'd also look for sepsis and SIRS in that patient, to be honest. Antepartum conditions that you want to look for, obviously, are interestingly enough, postpartum conditions, same conditions, but they count if they're antepartum or postpartum. Orthopedic issues in OB. Why was it hard to get the baby out? Okay, what was wrong with the mom? So here are your conditions under CMS that make a difference. Social history, whether there's a drug dependence, whether it was, did it affect the fetus? Was it with the delivery? And then clots and embolisms that you want to document, okay? In OB, you also have a special documentation, obstetric shock with delivery, with mention of postpartum complication, or if there wasn't an antepartum, with or without, okay? So those are your options. Always document multiples, okay? And make sure when you're doing those notes, you know, baby 1 of whatever, baby 2 of whatever, baby 3, you know, get all of them, get credit for each of those deliveries as you do it. You want to document your bleeding events. So it's, you know, hemorrhage from placenta previa or delayed secondary postpartum. But the whole idea, here are the things that complicate in a bleeding manner for obstetrics. You want to be able to have any of those on your chart. Well, obviously, lacerations and going by the degree of laceration, these are the ones that Medicare is looking for, and anything that made your delivery more difficult. So if there was a rupture of the uterus or an early onset of the delivery and it was unspecified, you weren't ready for it, that, any of those kind of things. Fetal distress, we want to make sure we capture that and write it down. And the reason I have all those listed, these are directly from the Medicare spreadsheets, okay? There's over 110 pages of complications and major complication comorbidities when you print it out. I'm sick enough, I've read it going across the country many times while I developed this talk, okay? I don't recommend you do. I recommend that you just take what I've given you as the gospel of what I need to document so that I'm compliant for Medicare. That's the best strategy. Whatever big intervention you do, you want to make sure if it's so big, it's so different, nobody else is getting it, I should have a diagnosis that backs me up and says why my patient needed blood, why my patient needed TPN, why my patient needed tube feeds or protein shakes. Okay, so severe protein energy malnutrition, or maybe even dysphagia for the PEG tube. So any of those things. And new onset dialysis, we got hammered. We wanted AKI to count. So the doctors lobbied Washington. Washington said, yeah, AKI is going to count, but you know what's not going to count? Acute renal failure. It's not going to count because it's so close to AKI. Criteria, it's really there. So it's only going to count if you document acute tubular necrosis. Now, you do enough looking at articles, acute tubular necrosis is present in all inpatient acute renal failures. Boom, quick escalation, it's acute tubular necrosis. The guy that's just a slow ride up may never really deposit, okay? But they're not coming in the building. People that come in with a creatinine of 1 and go up to 6 and we're dialyzing, I want you to defend your house with acute tubular necrosis. These are some of the things that we say all the time. We know it. Coders need it differently. So the hip fracture is an osteoporotic hip fracture, okay? The stage 4 lung cancer, remember, it's lung cancer with Mets to the brain. You want to specify that. Hieroglyphics don't count. We can't do that. Overall, we have an infrastructure here for you. Okay, Miranda, are you still in here? There's Miranda. So Miranda is one of our experts. Okay, she might be sending you a query. When she does, all we want you to do, answer it in the chart. If you agree that, oh yeah, I was treating it, I just forgot to write it down. Thanks, Miranda, you're helping me out. That's her job. Okay. Yeah, if it wasn't so, okay, why don't you just answer the email, tell her, if you see her, tell her why, so we get some good synergies here. But that's kind of what we do. Other things, as attendings, CMS says, when we sign resident notes, we have to actually put in specific areas. So if I'm treating the heart, I want to take in my heart exam in my documentation. Heart regular rhythm, no murmurs, no gallops, lungs are clear. Okay, chronic systolic heart failure, stable, we'll continue to manage with surgical team. Boom, that's all I needed to put in along with the resident note when I sign the resident note. That's compliant. If I just put in a line that says, I saw and agree with resident, CMS says that doesn't constitute a attending physician note. So we want to know that and take care of that. Overall, the other thing, anything you evaluate, you manage, you treat, you're allowed to write down. In the outpatient world, you're told you can't do a rule out. You can give a symptom for back pain for an x-ray. In the inpatient world, we don't have those restrictions. If I suspect it, I can write, I suspect this, You're allowed to work through and have a big, broad work list, and then cone it down to what you've ruled in and what you've ruled out. So I thank you for your time, and I beat the time allowance by 6 minutes, so you have time for coffee. Yeah.
Very nice presentation. I just have a question. What at least rules apply to private insurance here?
So it's kind of a trick question. Yeah. Sure. So the first question is, do these rules apply to private insurance carriers? So when they evaluate what we've done, yes, they use the MSDRG system. Here's the problem. Other words that Medicare has invented, like observation status. Medicare's observation status and say WellPoint or Anthem's observation status, or even worse, Humana's observation status, they're not the same. And that's because they're allowed to make their own rules. They just keep taking the words and then applying their own policies and procedures. So there's a bit of ambiguity in what we do.
And then the second question, would you mind sending your presentations to Miranda? Because I noticed some of the things here are kind of small for me. I'm getting old, my eyes are on it.
Yeah, we can print you out a full size. So. Any other questions? Yeah.
Another recommendation on how to document this is just progress. There's just keep like a running tally of every one of those things that you come up with.
So the question is, should we do a running tally of everything we come up with? If you're evaluating, managing, treating it, you should mention it. How many times do you need to mention something? Okay, like if it's certain things like severe protein energy malnutrition, a couple times because you're taking care of it. If it's sepsis, it's it's kind of like in church, as it was in the beginning, is and shall be forever. Okay, so you need to have it at the beginning, throughout your note, and on your discharge summary. Or else they say, well, yeah, it really was, sepsis was just secondary. So, yeah.
Enjoy a call. Question about also, so when the procedure that we can take is dead and it's
Yes. Well, okay, so the first part, medical legal. Yeah, is there doing your op note? Now here's what I'm going to say. When I talk about a complicating feature, patient came in with hypoxemia. That didn't mean we did anything. Okay, if in surgery we have unexpected bleeding, my wife's hysterectomy, a lot of unexpected bleeding. Okay, there's a lot of inflammation from an infection and everything else going on. That wasn't a medical legal issue, but she required a lot of work. Okay, so we want to document that. When we have something like that and we don't get it well documented, it does allow to the imagination of malpractice attorneys, right? So I think your best is very accurate in understanding and avoiding misstepping into creating complication codes. And I'll give you a great example. Our spine surgeon had a very high complication rate, and we were looking at the data. I mean, this guy's excellent. And here in the procedure, there was no way to do the procedure without having to remove tissue and tearing it down. It's part of the procedure, it's expected, but our coders were calling it a complication code because it was a tear in the tissue. They thought it was unexpected. When they got together and they worked together, it was, oh no, not a complication code. So if it's useful to work with quality and look and see what are our complication codes in our department. Then start to look at each case. Was it a real complication or did we put ourselves in the box?
One more question. Thank you all for coming, and John, thank you for coming. That's very informative. Thank you very much.